Hi, I am Dr. Anoop Thomas. I am working as consultant neurosurgeon in Aster Medcity, Kochi, Kerala, India. Today I would like to talk about low back pain. Low back pain is a very prevalent problem worldwide. It is said that 90% of the people have low back pain at least once in their lifetime. The back pain can be persisting. It can remain in the back or it can come to the legs. When it is coming to the legs, it is known as sciatica. Sciatic nerve is the main nerve which supplies the leg. So there are two sciatic nerves originating from the area of the spine and coming down to the legs. So when pain radiates along this area, it is known as sciatica. The structure of the spine. The spine consists of different bones stacked upon each other. To enhance the mobility of the bone, intervertebral disc, which over a period of time can give rise to wear and tear, and the inner content of the spinal disc can come out and irritate the nerves. So when it comes and irritates the nerves, it produces pain in the area of distribution of the nerve. So that's why we experience pain along the leg when we have a problem actually in the back. One of the important things or one of the consoling things is that 90% of these sorts of pain settle with time. But in some people, this can persist for a long amount of time and it can affect their work and their livelihood. So that is when we need to do something major about the pain. In some people, this pain will settle with medicines and other conservative measures. And when the pain settles, they can be initiated on physiotherapy to strengthen the back so that the bone is optimally supported. The lowermost spine regions, that is the L4-5 and the L5-S1, these are the most mobile segments out of the whole spinal segments. So it is these regions that generally degenerate the most. So what are the pain sensitive structures in the vertebral column? These are the ligaments, the intervertebral discs, the nerves, the facet joints, the dorsal root ganglion. All these are the source of pain. So when a person comes to a doctor, or a spine surgeon, his job is to find out what is the actual structure which is giving rise to the pain. So this can be elucidated from a detailed history, the characteristic of the pain, a clinical examination, and also investigations. MRI is the investigation of choice. Although some patients do have some apprehension about the MRI and some of them are claustrophobic, meaning that they can get frightened inside an MRI suit, but it still gives a very detailed information about the spine. Once the pain is diagnosed, most of the patients settle with medicines, physiotherapy, physical therapy, and things like that. But in some patients, the compression might persist, or in some patients, the pain might persist without severe compression. So in persons without significant compression and long-standing pain, it might be attributed to the chemical contents of the disc coming and irritating the nerves. So in these patients, we do offer a transforaminal or an epidural injection, which will relieve the symptoms to a great extent. In this, we inject a mixture of local anesthetic and steroid medications that acts on the nerves and decreases the pain. What are the surgical options? There are different surgical options for relief of the disc pain. Among the simple ones are the keyhole surgeries like microdiscectomy, tubular discectomy, endoscopic discectomy. So it started with laminectomy and discectomy, where we used to remove the bone a lot and then address the disc. But over a period of time, it has evolved to microdiscectomy, which has become the standard of care. In microdiscectomy, what we do is, with the help of the operating microscope, we remove the disc, only the herniated portion, so that the rest of the disc can function. So the fragment which is causing compression onto the nerves are removed surgically with the help of an operating microscope. But we have evolved further from these, and we are now using tubular techniques and endoscopic techniques more. In the tubular techniques, a small tube is inserted into the spine and the disc materials are removed through that. The result that the patient's muscles are preserved, there is no harm to the ligamentous structures, and the bony anatomy is well preserved. So this is a day case procedure, meaning that a patient can get admitted on the day of surgery and he can also get discharged in the same day. Then the further evolution or the newer techniques is the endoscopic discectomy. So through the endoscope, we can visualize the nerve roots and we can also see the disc which is causing compression onto the nerves. These are removed through the endoscope and the patient recovers from the surgery much faster. So the wounds are again made smaller, the hospital stay is also short, and the recovery is faster. There are some young patients in which there will be an inherent instability or differential movement of the spine which can happen. This is known as spondylolisthesis. In such sort of patients, we will require screw fixation in addition to the disc removal. So this is done through a procedure known as minimally invasive transforaminal lumbar interbody fusion. So this surgery takes around 4 to 5 hours, and what we do is we put screws through the computer-aided navigation, and we also remove the disc through the tubular approach and place an interbody cage so that the bone fuses. Pain arising from the facet joint. Sometimes the pain can arise from the facet joint, and this is characterized by pain on bending backwards. So some people do have it, and there are different modalities of treatment for it also. One of them is giving an injection to the facet joint and addressing the pain. In patients with established facet joint pain syndrome, we have an option of ablating the nerve supply of the facet joint with a radiofrequency ablation, and this gives a better long-term control of the pain. In some patients, the pain may be from the sacroiliac joint, which is the joint which is attaching the spine to the pelvis. This can give rise to the sacroiliac pain, which is felt typically in the just lateral to the spine, just in the by the side of the spine. So the doctor can identify it by clinically testing and also by investigations. So these can be managed by focused injections to the sacroiliac joint. In persons with long history of sacroiliac joint pain, it is evaluated with the help of the rheumatologist, and the treatment of the sacroiliitis should also happen simultaneously. The most devastating form of the disc pain is the coda equina syndrome, where the nerves to the foot and also the urinary bladder and the anal sphincter gets affected. So this can give rise to loss of control of the bowel and bladder movements. So this needs to be addressed immediately. So